So I'll be talking on all inside ACL reconstruction tips and tricks. I won't be going into the literature much, but just showing the certain steps which we do differently in all inside ACL reconstruction. So what's the difference from a standard anatomical ACL reconstruction? So there's no tibial screw involved. Rather, we use adjustable loop buttons at both ends, and we create sockets rather than tunnels. And the most important and the most helpful thing is that we can cinch the graft at both ends, even after tensioning and cycling the knee. So as we go along the steps of the surgery, I'll tell you what is a little different in each of them. So when it comes to graft, semitendinosus is mostly enough. Okay, I need to reduce. Yeah, and you should not have a tendon length of more than 280 mm. And so that when you quadruple the graft, you have a graft between 60 to 70 and not more, because otherwise it will not bottom out well into the socket. And a graft diameter of 9 or 10 is ideal. When it comes to graft preparation, the graft which is used in an all inside ACL reconstruction, they have termed it as a graft link. It is made with a buried knot technique using a number 0 fiber wire. So once you have the quadrupled the graft and put your adjustable loops into it, you tie the loose ends of the graft with a vicryl suture. It's a 2-0 vicryl. And then you start preparing the graft link on a graft board preferably. So first you pass the ethibond or the number 0 fiber wire through 2 strands. Then you go in a reverse direction, and then you go through all the 4 strands, and then you again go in the reverse direction and all the 4 strands. So 3 passes. Then you wind the thread across the graft for 3 times. So you make 3 rounds like so, and then once you've done the 3 rounds, then you tie 3 knots over it. So 3 passes, 3 rounds of suture, and 3 knots. So that is how I remember that. And then once you've cut that, you pass the suture again into the graft and then pull it snugly so that the knot gets buried into the graft. So that is how you make a graft link. And this is how it should look. So the femoral tunnel, you can drill it with a flip cutter, or as we do in a standard anatomical ACL reconstruction using an accessory anteromedial portal. Just the most important thing is that you should have a 2 mm posterior bone bridge so that you don't have a blowout. The big proponents of all inside ACL reconstruction, like Adrian Wilson, they prefer using a flip cutter because of the certain advantages, but I believe it's a personal choice. Things get different in ACL all inside when we come to the tibial drilling. So on the tibia, you have to use a flip cutter or a similar instrument from any other company. The tibial jig remains pretty much the same, but there is a special bullet for all inside ACL reconstruction, which has a 7 mm tap-in step tip. So once you tap this bullet into the bone on the anterior cortex of the tibia, the flip cutter, when you are drilling it retrograde, it does not breach the anterior cortex of the tibia. And that is what we want. And that is what we mean by a socket. So this is how it looks on the inside. You have to be very precise with your drill because you don't get a second chance most of the times because it's a flip cutter. So you have to be in the center of that footprint wherever you want it. You go inside a little. Before flipping, you should see the hinge. So once you see the hinge, then you start a retrograde drilling, you measure. And then once you are done with the drilling, you come out, I come out with only hand. I don't drill it when I'm coming into the joint. You unflip the flip cutter and then you come out. So that is how it looks. So this is a 9 mm tunnel on the inside, but on the outside, if you look, it won't be a 9 mm tunnel on the anterior cortex of the tibia. So before you are passing the graft, you have to mark the graft. The marking is done on the femoral side of the graft. So one is on the loop, which is about the length of the femoral tunnel, which we have measured. And one mark is on the femoral graft, which is at about 15 millimeters, because that is the amount of graft you want in your tunnel. So graft passage, one important difference is that the graft is passed through the accessory anteromedial portal and not through the tibia as we do in a standard anatomical ACL reconstruction. So that portal has to be large enough to allow the passage of a 10 graft. And you can use a flexible cannula, or you create a virtual cannula so that you don't have any soft tissue bridge. So suppose if you see this black circle, that is the portal. Both your sutures which are relaying the femoral and tibial side of the graft should be passing through that black circle. If one is not passing, then you will have a suture, a soft tissue bridge in between, and that would cause a problem. So your one bead pin goes from the accessor-anteromedial portal to the femoral tunnel, and the other is passed retrograde through the tibia into the tunnel. And then you take both the relaying sutures through a suture manipulator into the accessory anteromedial portal, so that there is no soft tissue bridge in between. So, and now once when you're passing the femoral graft, you should make sure that the other bead pin suture of the tibia is kept taut, and the button is parallel to the sutures. So, and there are three ways of knowing when you have flipped the endo button. So if you see the red arrow, that is actually the mark you have made on the loop with the pencil or pen. And then the blue mark is actually you see your button passing through the tunnel with your scope. And the yellow mark is basically that some companies have flipping sutures with which you can flip the endo button and see but cinching on the femoral side. And you see that your mark is, whichever you marked on the graph, goes up to the femoral tunnel. So in this case, it's the ethibond suture. Once you have passed cinched on your femoral side, then you start on the tibial side. So this is where the soft tissue impingement should be always be taken care of. And once you have passed the sutures into the tunnel, you can see it under vision and do it, so that you can see your button going in. Initially, I used to give it a tug, but now I go very slowly, and this is how it gets out, and the button gets out, and your graft gets into the tunnel. You can use a probe sometimes to direct it properly. So once that's done, you cinch your graft on the tibial side as well. One precaution I would say is always do it under vision. I've had a case where the button somehow managed to get into the small hole, and it was a big problem then. So always do this step under vision. Once you have done that, you cycle the knee, you tension the graft, and this is where all inside reconstruction is such a boon, because after cycling, sometimes we see that the ligament, the graft is lax. So what you can do is you can again cinch on both sides, and you can see right now that the graft again tensions up. So this is what is a very good thing about all inside ACL reconstructions. Once you're cinched, your graft is tight, you tie the cinching sutures on the endo button. And I have started now tying it on the femoral side as well. And then you cut the sutures a little longer for further revision if required. So in the end, why all inside ACL reconstruction? Because we are creating sockets rather than tunnels. We are saving bone. The chances of windshield viper and bungee cord phenomena are less. Semitendinosis is enough, so there's less morbidity. Small graft lengths are acceptable. There is less functional deficit. There is less post-operative pain. And especially in cases of soft bone, where the interference screw does not hold the graft well, this is a much better way of fixation. And the best part, as I tell you every time, you can cinch again after tensioning, and it is a very good scenario for a physical sparing reconstruction in skeletally immature patients, and it is very much bone preserving when you have to reconstruct multiple ligaments. And there's a lot of literature support for all inside ACL reconstruction. Thank you.